Good morning. Thank you all for coming back in. And we're going to get started so we don't keep you from lunch too late. And what I am going to be talking to you about is really the nitty-gritty about how the Texas newborn screening functions, what we screen for, and what our processes are. So, as Dr. Kemper has alluded to, the basics about newborn screening is it's a program that screens in Texas right now for 30 congenital and heritable disorders. The disorders may cause severe intellectual disability, chronic illness, death, with no clinical symptoms detectable at the time of birth. Early detection and treatment leads to dramatic positive outcomes for most affected babies, and typically treatments through diet control, hormone replacement, and medical supervision. So, when do we do the screen? The timing is everything. Many disorders cause irreparable damage in the first days of life. Changes in diet and/or other simple interventions can sometimes prevent lifelong consequences. And if an abnormal newborn screen result occurs, prompt follow-up is critical. Accuracy in testing and correct demographic information are essential. So as of December 2012, Texas screens for 30 disorders. There were 29 rare disorders that are the newborn screening blood spot specimen that Dr. Kemper had alluded to, and we'll talk a little more about those. And congenital hearing loss is considered another newborn screen, and that's a point of contact screen. We have an advisory committee. The Newborn Screening Advisory Committee was only formed in 2010. It's a 9-member committee. There are 2 additional members that were added in 2014, and its purpose is to advise the Department of State Health Services on strategic planning, policy rules, and services related to newborn screening tests. So in Texas, the hearing screening is called TEDI for Texas Early Hearing Detection and Intervention, and it can be accomplished by one of 2 ways. One is otoacoustic emissions, and the second way is automated auditory brainstem response, or what we used to call the BEARS. The timing on this is that screening occurred before 1 month, 3 months for confirmation of diagnosis, and treatment before 6 months. In reality, we really want that treatment to start much sooner and the diagnosis to be confirmed so that child can be entered into services. And as Dr. Kemper had alluded to, with the newborn hearing screening, there is a large number of children that were said to be lost to follow-up after they have an abnormal screen. But as he alluded to, most of that we think is related to documentation, so it's really lost to data entry. Texas does have 2 grants that are working on to decrease the loss to follow-up rate. One's a HRSA grant and the other's a CDC grant. And both of those are looking at both interoperability to make it easier for the provider to report the results back to us, as well as trying to track and figure out causes of the loss to follow-up, or quote-unquote the loss to data. So the newest screen that we're adding on is critical congenital heart disease. That screen is going to be effective September 1. We're waiting for the rules to be finalized, and as of September 1, that will be a required newborn screen. So about 1% of all babies have a congenital heart defect, but only 20 to 30% of those are considered critical congenital heart defects. 2 per 1,000 are potentially lethal or critical and require expert cardiac care and intervention with immediate newborn period or early infancy. In the U.S., about 4,800 babies are born each year with critical congenital heart disease, and it's one of the leading causes of death in infants under 1 year old. So for CCHD screening, the committee that Dr. Kemper referred to, or what I'm going to call SACADONC, in 2010 recommended that CCHD be added to the newborn uniform screening panel. In 2011, it was endorsed by then Secretary of HSS Sebelius, and in 2013, Texas House Bill 740 added CCHD to the core panel in the 83rd regular session. So, of the children that have critical congenital heart disease, We think about half of them are going to be diagnosed prenatally by prenatal ultrasounds, and another 25% are going to be symptomatic within the first day of life. The recommended time of screening is at 24 hours of age and older. So of all of the kids with CCHD, our estimate is that there'll be about 25% of those kids who will be undetected. And these are the babies that look fine, get sent home from the nursery, and they come back either dead or with severe life-threatening episodes and tend to have long-term sequelae from that episode. So what constitutes critical congenital heart disease? There are 7 conditions, and we'll go over those in a second. But just to remind you, the reason why we suggested 24 hours of age is fetal circulation is different than postnatal circulation. And in the fetus, there's what's called a patent ductus arteriosus, where the flow is coming through the patent ductus arteriosus to distribute it to the body. In neonates, that closes. Here it is. That closes within the first 24 hours of life. And we suggest screening 24 hours of life or greater so that you don't have false positives while the babies are transitioning to fetal to extrauterine circulation. The 7 defects are hypoplastic left heart syndrome, pulmonary atresia with intact septum, tetralogy of Fallot, total anomalous pulmonary venous return, transposition of the great arteries, tricuspid atresia, and truncus arteriosus. So how's it done? Dr. Kemper alluded to pulse oximetry, and there's a pulse ox. Now, you can't just go to Costco and order a pulse oximeter to be used for newborn screening. Although they have them for about $45, the recommendation is that it's an FDA-approved motion-tolerant pulse oximeter, and there are several that are now on the market that are acceptable, and the FDA has endorsed for screening for critical congenital heart disease in neonates. So what's abnormal and what's normal for this? So when you put a pulse ox on a baby, you're looking at a preductal and a postductal. If the baby has greater than 95% in the right hand and foot and less than a 3% difference between the right hand and foot, the baby passes. If the baby SAT is under 90% in the right hand foot, it's don't pass go, you automatically fail. But those that are in between for the 90 to 94% or greater than a 3% difference, you can repeat the screen twice before you actually, about an hour apart, before you actually call them positive or fail. So what happens if a baby is positive for the screen for CCHD? The confirmatory testing is a pediatric echocardiogram. It is, and hopefully a pediatric cardiology evaluation as well, both of those. So we know that when we go statewide, it is challenging for some hospitals because they may not have the ultrasound capabilities or they may not have a pediatric cardiologist. All of the birthing facilities in Texas have transfer agreements in place for children that are in trouble, and they already have those in place. Now, we also require nurse midwives as well, and someone had asked about those births. They're required to do newborn screening, both blood spot and the point of service. They can refer to someone else. There are some rules around, the age of the baby. If they're under 10 hours of age, obviously they don't get screened, but follow-up is required. So this is really a statewide screening for critical congenital heart disease. About a year ago, we surveyed all the nurseries in Texas, and of those that responded, about 60% were already screening for critical congenital heart disease by pulse oximetry. And of that 60%, about 80% were using a logarithm that was considered an appropriate logarithm. So many of your nurseries are already doing it. Every nursery is going to have to do it by September 1. We do have toolkits available. It's available on our website. It's available on the Texas Pediatric Society website. And it's also up on Baylor's website and UT Houston San Antonio's website. And the toolkits include how to train nurses, there are brochures, there are videos, there are vignettes, and there are screening logarithms up. And these cards are also available. These have been printed up and are available, and there are posters that are available for your nurseries as well. So moving on to blood spot-based screen, and these were the other 29 we were talking about. In Texas, we screened twice. I think that skipped one. The disorders fall into the following categories: organic acid disorders, fatty acid oxidation disorders, amino acid disorders, hemoglobinopathy, endocrine disorders, and our favorite, others, when you can't quite categorize them into one of those categories. These are the 29 rare disorders. We don't expect you to memorize it, but we did want to put it into your slide pack so that you at least had this for reference. In 2009, we added testing for cystic fibrosis, and our screening method is IRT DNA, which means that, we have elevated immunotrypsinogen. If it's elevated on the first screen, you'll get a report that says indeterminate. On the second screen, if it's still elevated, it'll then be reflexed to DNA screening, which is the ACMG, or American College of Genetics and Genomics, recommended panel of 40 mutations plus 3, or polymorphisms. Currently, we have about, on the dot, 300 children diagnosed with cystic fibrosis since we've initiated screening. And those numbers are going to continue to come up. The newest blood spot-based screen we added was severe combined immunodeficiency. And this is actually not detecting a single condition. There are about 15 or 20 conditions that are detected. It's detected by a method called TREX, or T-cell receptor excision circles, which is really a marker of T-cell maturation. So as the T-cell matures, it clips out this little TREC, and it's looking to see the number of TRECs. So a baby who is affected with severe combined immunodeficiency would have very low or no TRECs that are detectable. So, and as I said, within that category, there are some enzyme defects, such as adenosine deaminase deficiency that's treated by enzyme replacement therapy. And there are various other conditions that are included within TREC. So, Dr. Kemper also alluded to Texas and the storage and use of residual dried blood spots. So in Texas, newborn screening is mandatory. The only exclusion is for parents' religious tenets and beliefs. That's the only legal exclusion. So this is talking about what happens to that dried blood spot after newborn screening is completed. So House Bill 411 on the 82nd legislature, and that was a couple of years ago, had new requirements regarding the storage and use of dried blood spots after completion of newborn screening. So House Bill 411 strengthened the DS management review and approval process of proposed uses of dried blood spots after screening is completed. And effective June 1st, 2012, it required parental consent for external public health research uses, and these were all going to be de-identified, and storage longer than 2 years. So the kit, newborn screening kit, came with a new decision form that was added onto. This is what a specimen kit would look like. And then over here, we're asking parental consent or parental decision to say, yes, you can keep my baby's blood spot for more than 2 years to be used for only public health research uses, and it gives permission for storage for up to 25 years. And if you say no, then that spot is destroyed within 2 years. And just so you know that destruction process has now started, because it's been 2 years since this process went into place. We find that we get somewhere under half, 40 to 50% of the kits that come in actually have a decision checked for each baby. And of those that have returned the decision form, about 70% are giving permission for utilization for public health research uses and retaining those dried blood spots for 25 years. And we did try and figure out why we had only half that were being returned. And what we found was that really the larger hospitals, the larger nurseries, were the worst performers. And that was because they were sticking the information into their packets with like 20 million other information for new parents, and it really wasn't being returned. Now, a parent can return this at any time. There are also forms available if a parent changes their mind. And when these children reach 18 or the age of majority, they'll also be able to alter, say, no, I want my spot destroyed, but who knows where we're going to be in 18 years. So, and this is some more information on what the decision form. As a healthcare provider, you're required to give this to the parents, and you need to check that the parents have received this decision form. And that's really where the healthcare providers is distributing and checking that it actually happened. Now, the important thing is that the use and storage forms do not allow the parent to decline newborn screening. As we've said, the only legal reason is for religious tenets or practices. So we've also got lots of questions about why we're a two-screen state. Many states only do newborn screening once. Our first blood sample is collected in the 24 to 48-hour period after birth or before transfusion or discharge, regardless of weight or feeding status. And that's kind of important because we do know that a lot of babies, premature babies in neonatal intensive care units are on TPN, and we get all sorts of varying results with TPN, although we can recognize that. The second sample is recommended to be collected at 17 to 14 days of age, and the later a specimen is drawn outside of this time frame, the greater chance the screen may not identify disorder, because all the cutoffs and all the laboratory procedures are maximized for babies within this age range. The second sample generally is collected by the pediatric provider or the primary care provider, family practice, whoever's taking care of that baby for their primary care. So what it means is that the first screen is also coming out, is very frequently coming out of the birthing facility where the baby was born, and then the second screen is being done in the primary care office. So if you have an abnormal first screen, often it's very difficult to figure out who's actually taking care of that baby, because by the time the screen comes back, that baby's been very often been discharged from the nursery. And it takes our nurses hours and hours trying to sort out who the actual provider is to notify to link that child to care. And so although it may seem trivial, we do beg you to please put the demographics in, because that helps us find the kids when we need to find them and will help us find them more quickly. So why do we do two screens? Well, the first screen tests for certain disorders that are picked up abnormal levels produced by the stress of birth. And these really refer to the fatty acid oxidation defects. A baby may have a defect in fatty acid oxidation. The stress of birth has caused the analytes to be elevated, and we detect them. But by the time the second screen happens, that baby is well fed and not fasting, and we know it can normalize even though the baby still has the condition. Early testing can mean the difference between life and death for a patient. And the numbers say that before newborn screening for one of the fatty acid oxidation defects, MCAD, or medium chain acyl dehydrogenase deficiency, the first presentation was death for over 30 to 40% of those children. And so it's a very cogent reason for newborn screening. For the second screen, some disorders may be missed on the first screen due to infant physiology. It's necessary to capture some of the disorders not picked up on the first screen, and as was alluded to previously, the CF testing protocol requires two screens. So when we look at the second screen, about a year or two ago, there was CDC did a study that looked at states that did first screens and second screens. That paper still isn't out in publication. We did, as Texas did, contribute data, and since we're so large, we contributed a lot of the data. It looked like it was mainly Texas data for the two screen states. So what we found was for congenital hypothyroidism, about 48% of the children had normal first screens and were being picked up only by the second abnormal screen. And for congenital adrenal hypoplasia, it was about 12 to 13%. And many of you know there's a spectrum of children with congenital adrenal hypoplasia, but we found that in that second screen, we also found children who were salt wasters. although some endocrinologists claim every child with CAH is a salt waster. We found simple virilizing, we found non-classical, but we did find children who had the most severe form of that disease who, if they did not get treatment, were at a very high risk of not surviving. So it takes a team. Who are we? We have laboratory services, clinical care coordination, which is where my home is, medical providers, medical facilities, parents, and caregivers. The laboratory services were huge. We operate 6 days a week. Testing processes begin on all specimens within 1 business day of receipt. Initial and critical values can be available in as little as 24 hours, and all results are reported within 4 to 5 business days. So we used to say we had about 400,000 infants born in the state. Our numbers are down a little bit. It's about 380,000 babies are born in Texas each year, and that does not include the military babies. About a year or two ago, the military decided they were going to use nationwide their own screening for all babies born to in military facilities. So that means we have about 750,000 newborn screens per year, and the laboratory receives approximately 2,500 specimens each and every day that the laboratory is open. That's large. We have the mass spec that Dr. Kemper showed you. We have 10 of them that are running continually. So what do these reports look like? And how do you get the report? Many of you, it's a black box. You send in the blood spot. You may or may not hear from us. What happens to those and after the screening is completed? We mail the result. The laboratory will mail the result reports for every newborn screen. Providers can look it up on a web application, which is password protected, and we'll talk a little more about that. And about 10% of our facilities use HL7 messaging, which is computer-to-computer talking. Demographics can be entered remotely and results go back, and that stands for Health Language 7. The web-based system is available to any healthcare provider. A username and password are required, and it features remote demographic entry, online access to patient results, and report cards are now available. And what report cards are is we're reporting back to the facility that X% of your specimens arrived on within the recommended time. You had somebody unsatisfactory spots received, and that's compared to the state average. So each facility will get their own data and a comparison to the state average. You can't look at another facility's data without their permission. And our goal is for all submitters to have access to the online system. So you can sign up, and again, this is a slide that's just here for your reference. You can download the forms, complete the security and confidentiality agreement, and submit the completed forms. So what does the newborn screening report look like? Well, on this screen, probably the most important part of this screen over here is a normal screen. We'll tell you we'll go by categories. We'll tell you what's been found to be abnormal. There'll be a lot of messaging down here, which in truth for a normal screen, most people don't bother reading. And sometimes for abnormal screens, most people don't bother reading them as well, I have to say. There'll be guidance in terms of what to expect. There'll be message clarifying the scope of newborn screening. There are messages, this is a SCID, there's messages identifying and clarifying what testing has actually been done. And then there's a list of disorders on the bottom that tells you what we're actually screening for. Now, an abnormal screen, here's what you have to pay attention to. There is an abnormal screen here. There'll be more information given to you. This is for SCID, and this has a very low number of T-cell receptors. And then there'll be some more information about further recommendations in terms of what is going to happen and what we expect and what we recommend further. And we ask you to act on those screens when you receive them. And then once the laboratory has an abnormal result, it is then immediately transferred to the clinical care coordination. And clinical care coordination consists of the medical director, that's me. We have registered nurses, and we have public health and prevention specialists. Each of our nurses in PHPS are assigned to specific disorders, but all of them are cross-trained for full coverage. We have educators, and we have the good fortune to have an ombudsman as part of our group. A case is opened for each positive screen result, and cases are monitored until an infant is cleared or diagnosis is determined. In fiscal year 2013, the laboratory screened around 745,000 specimens. 16,000 of those had abnormal screens that required follow-up by clinical care coordination. And of those, for 2013, there were 750 confirmed diagnosed cases. Usually we run around 750 to 800 per year of diagnosed cases. So when that screen is abnormal, the first thing we're going to do is to try and find the medical provider. The test that was done, the laboratory report, is going to go back to the submitter. So whoever submitted that sample will get the laboratory report, those two reports I just showed you. You'll get more information from clinical care as well, coordination as well. We will start trying to find the medical provider responsible for the medical care of that baby. First thing we do is determine if the baby's still in the hospital. If we can find the medical provider, we'll give the results and provide guidance for recommended actions. If we cannot find the provider, and this takes a lot of time, we'll contact the parents to obtain a PCP. If the PCP is not identified, we will provide the results to the family and direct the family to an emergency department if necessary. And if that happens, the clinical care nurse will coordinate with the ED staff if the family is directed to an ED. Now, one of the things I'm going to make a plea to you is please do not call newborn screening PKU. We have lots and lots of folks who say the PKU test. You know, there are lots of them. And I have to say, part of this is selfish. It's for the benefit of the babies. But I get called at 3 a.m. for a baby that has a, quote, abnormal newborn screen for PKU. And it turns out it's not PKU at all. So I got called at 3 a.m. from a tertiary care children's center wanting to find formula for a baby with PKU at 3 in the morning. So, right. So it takes us a little while. It took a couple of whiles, and I had no clue what was wrong with the baby. And this particular center did have a metabolic doc. And when I asked the emergency room why they didn't call their own resources, they said, we did, and he said to call you. So, you know, at 3 in the morning, the one thing about our web-based system is results don't go on until all of newborn screening is completed. So you're going to hear from clinical care coordination long before all test results. You'll hear as soon as we have an abnormal, so it won't be in the web-based system. Well, it turned out for this baby that our nurses had been working the case and that all of the information had been provided. The baby was transferred from a rural hospital into the tertiary care center, but somehow or other the paperwork didn't make it, and all they knew was the baby had an abnormal PKU. We got it sorted out. At 3 in the morning, it was like, okay, he may have a fatty acid oxidation defect. We don't want him starving. Give him something, you know, Pedialyte or something with some glucose in it. But yet we didn't know whether he had a protein, a problem handling proteins, if he had one of the metabolic conditions that he couldn't break down the proteins. And so for 2 hours or so, we temporized with the Pedialyte. And then by 5 a.m., we had it all clarified. This baby actually was at risk for congenital adrenal hypoplasia. So we cleared him, we called back, we said feed him whatever you want, breast, whatever, doesn't really matter. And in actuality, we actually had cleared him from congenital adrenal hyperplasia with the confirmatory testing by Saturday morning, or some of the confirmatory testing by Saturday morning. His newborn screen had normalized. And I just had this feeling that it wasn't being followed. So I had one of our nurses call back later Saturday to ask what they were feeding this baby. And the answer was, we're feeding him Pedialyte. Dr. Friedenberg told us to do it. So we cleared that baby. Luckily, we got to clear that baby, and the baby was put on breast and went on to be treated like a normal neonate. So if we can't find, after we've notified the family and we've called the delivery facility, and we really can't find that baby, we utilize DSHS regional social workers to assist with locating the baby. We connect the baby with healthcare providers, which helps connecting the baby with local healthcare providers and other services. And if all else fails, we will involve other agencies, including law enforcement and CPS as necessary. Luckily, we don't have to go there to law enforcement frequently. Our social workers are being utilized, our regional social workers are being utilized on a daily basis. Now, the regional social workers are not dedicated to newborn screening. They have lots of other responsibilities in the region, but they will help locating babies. So if a screen is positive, what happens then? We distribute resources. We send information mailed to the parent, a newborn screening letter, and general newborn screening brochures, and a lot of those brochures are out on our exhibit table, and please help yourself. For a positive screen with a very elevated level, it can be a medical emergency. It's reported immediately to the nurse in clinical care coordination. The PCP is notified by phone, fax, and really they bug the bejesus out of them until they wind up doing something about it. And again, if no PCP is on record for the newborn, the nurse will notify the parent directly. The faxes to the medical provider, we send a newborn screening letter with newborn screening specific disorders lab results, with contact information for the nurse following the case, and disorder-specific act and fact sheets, as well as a list of regional subspecialist consultants. So for the ACT sheet, these are adopted from the American College of Medical Genetics and Genomics. It's designed for the medical provider, and it contains the following: the differential diagnosis, a description of the condition, and the black box for medical emergencies. Follow the instructions outlined in the black box. And these also are available on our websites for anyone who wants to take a look at them. We also send fact sheets, and these are designed to have the provider speak with the family and give them some more information to share with the families. Each disorder has a fact sheet that, again, is modeled on the ACMG fact sheets. The fact sheets for ACMG have now sort of gone away because now there's the clearinghouse that Dr. Kemper referred to that's meant to give information to parents. It's designed for the PCP to share with the family. It gives some information to the parents about symptoms, treatments, and things to remember for specific disorders. And again, it's available on our website in both English and Spanish. And we will continue to utilize the fact sheets, although we've modified them from ACMGs and incorporated the other information from the clearinghouses from Baby's First Test. Well, medical providers and facilities have responsibilities as well. The birth hospital has to assist with locating the baby and identify the PCP. The PCP has to agree to follow up with the newborn and family, accept the patient into their practice, which is not as simple as it sounds, because we have identified several cases, although it's usually not the norm, where the baby has gone home and has been assigned to a PCP, but the PCP is not accepting any more Medicaid patients. And that can cause some delays in trying to find a PCP for the baby. And refer to the subspecialist as appropriate. Parents and caregivers also have responsibilities. The parent provides PCP information to the clinical care coordination. They follow directions, but they really have to ensure follow-up of the newborn that attends appointments and it receives treatment and care if diagnosed. So that's all short-term follow-up. Texas does do long-term follow-up, and Dr. Kemper alluded to this a little bit. And our goal is to ensure the best possible outcome for individuals with disorders identified newborn screening. Now, many people say, okay, you're a newborn screening program, why are you continuing to follow these kids? And we really have a number of components in there, and long-term follow-up really is just being developed more fully over the last few years, and will continue further development. Its components are care coordination through a medical home, evidence-based treatment, continuous quality improvement, and new knowledge discovery. So what's involved? At the time we have confirmed diagnosis, we send the family a letter saying you're going to hear from us again. We'll be checking in with you to let you know, to try and figure out how your baby is doing. It's continuing PCP specialist visits. We will send the specialist once a year. Depending on the age of the baby, for some conditions, there'll be follow-up requested at 3, 6, 9 months, and a year. Usually after a year, it's a yearly form that we ask for follow-up. We ask for continuing documentation of treatment, parental involvement, physician and specialist participation. And all the specialists are really busy, and sometimes it's a little bit of a tug of war trying to get the information back from a busy clinician, and we can't blame them. I mean, data entry is often on the lowest priority when you're caring for a patient and your clinic's stacked up, you have tons of patients to see. Our hope is that eventually when EMRs mature, electronic medical records mature, that they'll be able to abstract the data directly without having anybody needing to be involved in extra work. How long do we follow the child in long-term follow-up? For some conditions, it's up to 21 years old, depending on the disorder. Some were 4, and these length of time for follow-up was based on what the subspecialist said they wanted. We're now trying to harmonize all of them to around 18 years. Why should we track long-term? We can evaluate the effectiveness of the newborn screening program, develop evidence-based treatment. A lot of these are rare conditions, and it's really expert opinion that's guided the treatment. We don't have any evidence-based treatment, and by continuing to follow, we hope to develop that, to improve the treatment of affected individuals, and to provide continuous quality improvement. In Texas, we do have what's called the Newborn Screening Benefits Program, and that was redesigned in 2007 to account for the expansion of the newborn screening disorders screen. It targets families without Medicaid or private insurance. It's designed to be a payer of last resort. So those with a presumed positive screen or confirmed diagnosis of a disorder screened for in the Texas Newborn Screening Program are eligible. And there are some income restrictions that the family has to be at or below 350% of the federal poverty income level and be a Texas resident. It covers confirmatory testing, dietary supplements, metabolic foods, low-protein foods, medications, vitamins, and follow-up care. And it also has a carve-out if that individual has insurance that does not cover, let's say, medical foods. If they would otherwise qualify for the newborn screening benefits, they can be qualified for that one particular area that their own insurance does not cover. So what's next? Well, the secondary conditions on the recommended uniform screening panel will be added to the Texas Newborn Screening Panel. There are 24 additional secondary conditions. Now, people get confused about what's core and secondary. So secondary conditions are believed to be clinically significant, but some may have unclear natural history or lack appropriate medical therapy that affects long-term care. And I know that there are some conditions on the secondary panel that a lot of folks believe is not a disease at all, and that's going to be interesting to tease out. It's detected during screening for the core conditions. The additional conditions will be detected through the same newborn screen specimen collected from the heel stick and tested at the Texas Department of State Health Services laboratory. No additional blood spots will need to be collected, and at this time, no additional fee is anticipated. However, the laboratory is under a requirement to review the whole cost of newborn screening panel, and that review is expected to happen in 2015, so those fees may wind up changing. This is a list of the secondary conditions, and again, we don't expect you to memorize them. They're here just for your reference. There are 2 conditions on the secondary panel that are exempted by law for a screening, and that's for galactokinase deficiency and galactosapolymerase deficiency. So what's next? Dr. Kemper spoke a little bit about Pompe's disease. Well, the original recommendation was due by July 31st, 2014. I don't think we've heard, but I do understand there'll be some more pilots recommended. And then the next 2 conditions are MPS 1, or mucopolysaccharidosis type 1, and X-linked adrenoleukodystrophy, and those have been sent to formal evidence review, which is the next step in moving the condition forward for consideration. However, also, as Dr. Kemper referred to, they are on pause now trying to figure out the public health impact of adding those, and so no more conditions are going forward until they develop the public health impact. And sometimes for the public health impact for programs, it's some very practical considerations. It's like we don't have any room in the lab to put any more instruments that are going to be required to do this testing. We don't have funding for more people. It's not just bringing it up, although there are lots of higher level issues. Sometimes it can be, as I said, as simple as we have no space where are we supposed to put this to add it on. And in Texas, when we've got lots of babies, that does become an issue, and the lab space is utilized to the ultimate right now. So let me give you an idea about how some of these work, and we'll go through a couple of cases. Baby girl D was the 3.4 kilo product of an uncomplicated term gestation. Day of life 2, her screen was collected. It was received on day of life 8, and no PCP was listed. On day of life 11, the results came to CCC. The hospital was contacted, and the hospital provided a PCP name. The PCP was notified of the abnormal screen, and guidance was provided, and a parent letter was mailed. On day of life 30, while our nurses were still trying to track this baby, the family called changing PCP, saying they were changing their PCP, but no PCP was identified. On day of life 32, the family phone was no longer being answered, and a certified letter was sent to the home. And sometimes when we send certified letters, people don't get it because they're worried they may be billed, so we'll send something regular mail as well. On day of life 32, the regional social worker to the home, an appointment was made with a new PCP. Day of life 38, the PCP office noted the baby scheduled for a lab draw, and they no-showed. Social worker went back to the home, a new PCP identified, and from day of life 43 to 1 year of age, that child could not be found. We think they may have been in Mexico, but we're really not certain. But the bottom line was that at 1 year of age, the baby was located, admitted to a PICU, or pediatric intensive care unit, with severe developmental delay and malnutrition. Now, congenital hypothyroidism is pretty easy to treat. You think you sprinkle a little thyroid hormone on them and they do well. But this is the point, that this is a system. Our laboratory and our programs in CCC did everything we could and followed protocols, but yet this baby still didn't get the care they needed, so it's a failure. And newborn screening is an overall system. It's not just the public health programs. It involves all of us, our colleagues, in making certain these kids get what they need. Okay, another case, and this is the way the majority of cases go. Baby girl G, 2.5 kilos, 36 weeks. Day of life 2, first newborn screening. Day of life 3 at the lab. We do now have some couriers that are picking up specimens to decrease the time in transit from when that specimen is drawn to when it's received at the lab. It's not statewide, but we do have, it's in the major metropolitan areas. Day of life 4, an elevated phenylalanine level, which is the marker for PKU, and an elevated phenylalanine to tyrosine ratio. Primary care notified, requested repeat newborn screen the same day, and was referred to a metabolic specialist by the PCP. Day of 6 life was evaluated by the metabolic specialist, confirmatory testing obtained, and by day of life 8, the baby was on PKU formula, and day of life 9, the diagnosis of classical PKU was confirmed. And that tends to be the way the majority of them go. However, we all know it's that 1% that doesn't go quite the way you expected that can cause lots of time and lots of angst. Okay, case 3. Baby boy T, 3.2 kilo product, uncomplicated pregnancy, specimen on day 2, received day 6. The day of life 7, the preliminary results showed a very elevated 17-hydroxyprogesterone, which is the elevated analyte that we see in congenital adrenal hyperplasia. The birth hospital was contacted and the child was already discharged. Newborn PCP was listed as the PCP, but when contacted stated they were not accepting new Medicaid patients. The family was contacted and no PCP was identified. The child was referred to the ED of a local hospital and guidance was given to the ED. The ED obtained the electrolytes, which showed a sodium of 133 and a potassium of 4.9, but they refused to obtain the confirmatory tests of 17-hydroxyprogesterone, saying that it wasn't going to impact their immediate management of the child while they were in their emergency room. So they refused to send the specimen. So we provided education to the ED, and that particular emergency department said that they had no pediatric endocrinology consultant, and there were none in the area. And we said, okay, transfer to a tertiary care center, and that transfer was arranged. Well, the tertiary care center requested the 17-OHP prior to transfer. So we wound up in this loop, and eventually they did obtain the 17-hydroxyprogesterone in the ED, but hours later. Day of life 8, we had a final of a very elevated 17-OHP. A regional social worker was contacted to help find the PCP. The social worker directed the family back to the ED for additional electrolytes with still no PCP. And by day of life 17, the child then was receiving specialty care, but there was still no PCP identified. So these are the things that take time, and these are the things that put kids at risk. Okay, last case I'm going to do is the case of CF twins. And baby boy Smith were 1.2 kilos and 1.8 kilo, products of a 31-week. At the time, we did not know that was a monozygotic twin gestation. Born to a 29-year-old gravida 1, parazera female by primary C-section. Pregnancy was complicated by a maternal unrepaired meningomyelocele with all the associated sequelae. There was limited prenatal care obtained in Mexico, but concern was noted of a possible twin-twin transfusion. And essentially, the doc in Mexico said, go to the U.S. to go get care. Maternal history noted the use of oral steroids due to, quote, maternal short stature 3 weeks prior to delivery. The mom was wheelchair-bound and had an unrepaired meningomyelocele, so short stature was the least of the worries there. The twins were delivered by C-section. They showed up in the U.S. They were delivered immediately. An indication at the time of presentation was twin A was noted to have fetal ascites, polyhydramnios, hydrops, and no end diastolic blood flow, which in other words meant this baby was trying very hard to die at that time. At the time of an attempted placement of an umbilical line, twin A had significant bleeding, and the decision to transfuse before obtaining a newborn screen was based on the clinical status. During the first day of life, the child received an enormous amount of replacement, fresh frozen plasma, red blood cells packed, cryoprecipitate, and platelets. And the child was noted to have an in utero bowel rupture. The first newborn screen was collected at 48 hours of life, and by that time the child had received a total of 220 ml of packed red cells, or 183 ml per kilo, and 125 ml of fresh frozen plasma and 20 ml of cryoprecipitate, which meant essentially the blood draws were not looking at the baby's own metabolism. Twin B initially appeared stable, but was noted to have scrotal discoloration, and during workup for the scrotal discoloration, fecal contents were noted in the scrotum, and further workup noted a bowel perforation. Newborn screen was obtained prior to transfusion for this baby. And so for twin B, the first screen was collected on day of life 2, received day of life 5, reported on day of life 9, and it was an elevated IRT, or immunoreactive trypsinogen. The second screen was collected on day of life 10, received day of life 13, and reported on day of life 20, and still had an elevated IRT, and then was reflexed to DNA. And the child was found to be homozygous, or have 2 copies of the common mutation associated with cystic fibrosis, or delta F508 deletion. We had requested a third screen because we weren't really certain which of the twins we were looking at, with the labeling sometimes getting a little confused. So at our third screen, on day of life 28, the IRT was elevated. Twin A was collected on day of life 2, reported on day of life 7, and the IRT was not out of range. The second screen again was collected appropriately, and again the IRT was not out of range. The third request, as we said, collected at our request, showed that the IRT was out of range, and the DNA studies, due to the twins' result, again showed that this baby was also homozygous delta F508 deletion. So we know that we're a screening program, and we know that children with meconium ileus and bowel perforation are much less likely to have elevated IRT and would not be identified, may be missed by the newborn screen, and that's why it's called the screen. We ask anybody who has any clinical suspicion to do a diagnostic workup and not depend on the newborn screen. And I think once you hear ruptured in utero bowel and meconium ileus, most people would start thinking about cystic fibrosis and start that evaluation. And so my point for all of this is that newborn screening is a program, and there are lots of moving parts with the baby at the center. But really, we're a much bigger system, and it requires all of us to take care of all these babies. And there are lots of parts, from policymakers on down to clinical care. And so really what I wanted to leave you with was the collaborative nature of newborn screening and how much we appreciate all the care you guys do for these babies every day. And so, any questions? I can't have left you speechless. Sure.
Real quick, what about the people that come into our office, that they've had their first newborn screen, but they refuse to go for their second? Sorry.
Well, the only legal reason they can refuse the screen is religious tenets. Now, newborn screening does not have a regulatory authority. Our only weapon, so to speak, is education. But as you heard, for CF, we need 2 screens to make a determination, and there are some conditions that may be missed. So we ask that you educate the parents about the benefits of newborn screen and, and proceed from there.
So that was the question that you proceed to. I mean, if we've educated them at this point and they're still not going, as long as we've documented that we've called the patient, educated the parent, re-ask them to go.
So the recommendation is that the documentation of the parental refusal stays with the child's chart. We never see it at the state.
Okay.
But you need to have either flag that chart or have a much higher index of suspicion if the child clinically presents with something, recognizing that their newborn screen was incomplete.
Thank you. I'm sorry.
The second newborn screen is 7 to 14 days.
Mm-hmm.
What's the latest time that we can draw that?
Well, the later you get out of those 7 to 14 days, the less likely we are to detect some conditions. We do take it up to 12 months, and for Texas Health Steps or the Medicaid program, the primary care provider is required to document that there are 2 newborn screens on the chart. Now, we'll actually test almost anything we receive within limits, because we know that there are children that are adopted into the state that have moved in that may or may not. Sometimes they're coming from Russia or from some other countries that most likely have not had a newborn screen. And I could tell you, I personally have seen a almost 3-year-old child that was adopted who turned out to have PKU, and their international adoption clinic had sent off a newborn screen, and they were identified on that particular screen as having PKU. Now, the oldest specimen, the age of the oldest person we've received was I think it was an 81-year-old gentleman who was sent to us because whoever sent it to us said they heard he had prostate cancer, and they heard that prostate cancer had elevated phenylalanine. We think he was confused and was thinking about PSA, but all I can say is we got a specimen from an 81-year-old looking for phenylalanine levels. And we've also, while we're on the unusual things we've seen, we've had a blood spot faxed to us with a request to run its stat. That was pretty interesting. That certainly got a call to ask why and with recommendations.
So really there's no age limit, because if there is actually a disease, you can pick it up no matter what age.
Depending on which condition it is, some we may not be able to. You have to realize that we look at cutoffs, and we design the cutoffs so that we pick up children of those particular ages. As the child gets older, the older children may have a different range of what we'd expect for them, but our program is not optimized to detect that.
So up to 1, that's your limit, your range?
We say up to 1, but the reality is we'll accept anything you send us.
And then you decide if it's...
No, we'll, if you send it to us, it will be run, but we send you back information saying this is out of the age range, and be aware that it's maybe less accurate, and that if you have any suspicion about that child needs a clinical diagnostic workup. Any other questions? Hang on, we got a microphone if you want to repeat yourself.
I have a patient that moved from the Philippines, and she came to the office at 9 years old. The kid looks like cretin to me, and the kiddo had a tetralogy of Fallot repair at Children's, about 5 or 6 years old. And then she came to the office at 9. The mother is a doctor, you know. So I said, your baby has something else? So we did TSH, and it was 150. And the kiddo is a congenital hypothyroidism that could have been, helped from the very beginning. So I felt very bad about it.
Yeah. Now, I do believe the Philippines is considering, I don't know what screening's actually done there, but I've heard they're working on setting up their screen. But that's, again, shows the recommendation that any kid that comes in, that's why we do it, because any child that comes into the state, we will run.
Yeah, I was talking to one of the doctors in the Philippines because we go there for medical missions, and I said about the neonatal screening of the children there, and they said, we're doing PKU and some others. I said, how do you pick up what to do with the patient? The ethnicity, and I think for cost effectiveness, I think you have to be a little bit specific. What are the diseases that you see in these kids here in the Philippines that can be treated properly or adequately? And I think one of those is thyroid disease and hemoglobinopathy, as well as congenital adrenal hyperplasia, because I think those kids can be helped very early on.
That's correct. That's the whole purpose of newborn screening.
Thank you.
Any other questions? Well, thank you. Our next move is to lunch, and I'm told it's around the corner on that side, and then we'll convene back. Did you need something? We'll convene back. There's also will be a statement out at our exhibit table about rationale for adding on secondary conditions to our screen. I think we're the 48th out of 50th state to do it. Thanks again, and we'll see you after lunch.